Welcome everyone to tonight's 11th installment of FAFP's COVID-19 webinars. My name is Dr. Chris Scuderi, and I've had the pleasure of chairing the FAFP's COVID-19 Task Force, which has been leading the FAFP's effort to assist Florida's family physicians and their staff in dealing with the COVID-19 crisis. Tonight's topic, Thriving in the COVID Marathon, will feature 3 family medicine leaders who will address 4 distinct questions as to how they are addressing the challenges, changes, and concerns associated with this unique crisis. Our presenters, as I suspect most will agree, are no strangers to the family medicine limelight from both the national and state perspective. First, Dr. Peter Carrick, who currently serves as professor and chair in the Department of Community Health and Family Medicine at the University of Florida, Gainesville. Among his incredible list of accomplishments, he is the former chair of the Accreditation Council for Graduate Medical Education, ACGME Council on Review Committee chairs, and chair of the ACGME Review Committee for Family Medicine. Next, we have FAFP President-elect Dr. John Gross, who practices family medicine, sports medicine at Baycare Medical Group in St. Petersburg. He is well known within Florida's sports medicine environment, having served not only as medical director for the Florida Ironmen, but currently holds the position of team physician for the Major League Baseball Tampa Bay Rays, who have beat my Yankees 2 nights in a row. So tough 2 days. Serving the best for last, we have FAFP board member and former president of the Uniformed Services Academy of Family Physicians, Dr. Maureen Patton. As a former member of the U.S. Navy, I am saluting her for her incredible naval career, which included serving as a commanding officer at Naval Hospital Pensacola, Florida. Welcome all. And Dr. Patton is having some camera issues tonight, so she's with us in voice, but we're working on the camera. Before we begin, just a reminder that similar to all FAFP webinars, participants will be in listen-only mode, but can type questions in the chat box that your presenters and I can see, and we'll attempt to answer either during or at the end of the presentation. Also, stay tuned in the coming weeks as we're looking to develop a webinar focused on the long-term effects of COVID-19 on our patients, with 3 distinct specialists presenting: neurology, pulmonary, and cardiology. Now let's get started with tonight's format, which will involve me asking the panelists questions and having them rotate through and answering from their own perspectives. We will kick it off by asking Dr. Carrick, what has been the biggest challenge during the past 5 months?
And I'm sorry, Chris, are the slides up?
They are.
Jay, are you able to get them up?
Oh, you can't see them? I'm sorry.
Can't see them.
All right.
So yeah, COVID sure has presented a lot of challenges, especially early on in the pandemic. When we first thought it was kind of going to be an exacerbation of a bad flu season, and probably many of us had no idea what the entirety of the whole pandemic was going to be. So the challenges we had to face were many, and some included changing our practice patterns. I'm sure late February, no one realized, probably like me, I couldn't even spell telemedicine, let alone use it. But now, all our faculty members are using it on a regular basis. The biggest challenge we faced in Gainesville, I'm sure many other folks, is how do you maintain a safe environment so folks, especially healthcare workers, don't get the disease, as well as addressing individual comfort levels. It depends on risk factors. Everyone's going to have a different level of comfort taking care of patients with COVID or taking care of patients that possibly could have COVID. The other big challenge we had was keeping up-to-date information, up-to-date and accurate information that we could relate to our physicians, our advanced practice providers, our nurses, staff, and patients, just to keep everyone as up-to-date as possible, kind of help alleviate some of their concerns and levels of discomfort. Already talked about the telemedicine, and the hard part too is the supply and demand. How quickly was it going to be adapted by patients, and how quickly were our physicians and APPs going to adapt to it, and could we always keep up with the number of telephone calls and video calls that were coming through? We did realize that there was a big need for face-to-face visits, and then, as you can imagine, that presented a whole new level of challenge. Started screening people, basically as they walked in the door, making sure they weren't at least having flu-like illness symptoms. How we were protecting our front office staff, our nurses, our physicians, because you don't want anyone to get sick, because once that virus kind of gets in an office setting, it can spread pretty rapidly, and all of a sudden you lose part of your healthcare force that you're needed to take care of the folks that are coming to see you. Big challenge, again, was the financial stability. Our patient volume dropped significantly. Our outpatient practice calls it the cliff Our hospital calls it the hole that we dug. And we're still trying to dig out of that financial hole. Unfortunately, there were programs, both state and nationally, that help us kind of navigate a little bit, but we're still trying to recover from those financial difficulties. And then finally, and I'd always remind our folks that we still need to take care of folks that don't have COVID, and how are we going to take care of those patients? A major concern we had, especially was the vulnerable patients, especially patients over 65, is were they deferring care? Were they just staying away from the office and the hospital just because they were so afraid of COVID that they were forgetting about their diabetes, they were forgetting about their hypertension? And when I was on the inpatient service in April and May, we did see folks that came in, and you could tell they should have been in 2 to 3 days earlier to the emergency room, but they just refused to come in because they were concerned about catching the disease.
Excellent. Thank you, Dr. Carrick. Dr. Gross?
Right. So I reflect a lot of the things that Dr. Carrick had said, but my biggest challenge during the past 5 months as a team doc for the Rays is convincing 14-year-old boys that are trapped in 20-something-year-old bodies to keep their hands to themselves and stop being disgusting all the time. And I've seen Major League Baseball be like a microcosm to the pandemic across the country, where in the clubhouse, we've had to put in protocols, convince the those that don't have maybe some faith in science, and get past a lot of cultural barriers to get everyone on board to ensure the safety for the entire team. You know, I included the Cardinals on there because, as everyone might have heard, there was outbreaks in different teams. We're not doing the bubble system as the NHL and the NBA are doing. We are keeping things in columns where the East Coast and the Midwest and the West Coast are the divisions in baseball. Well, there were outbreaks with the Marlins, and there were outbreaks with the Cardinals. And I'll tell you that's what scared the players straight. And I see the parallels. I see the parallels with how those players reacted with a lot of what the public has done to react to the pandemic. And I've also seen them accept the new normal, which is a culture of washing your hands all the time and wearing a mask. And again, you know, don't be disgusting. Which I have to say over and over and over to these ball players, to the point where I feel like that's one of my catchphrases that they associate with me, which is only appropriate since I'm Dr. Gross. This thing needs a laugh track, I think. So anyway, that would be my biggest challenge. And you know, I don't want to take anything away from what's already been said, because I would reflect all of those comments made. But getting these guys to circle the wagons has been a monstrous challenge, and it continues day to day.
Excellent. Thank you, Dr. Gross. And so next, Dr. Patton.
Well, hey, everybody. Sorry you can't see my face, but I promise I'm here. I will agree with everything everybody said so far. I think one of the first things that hit me was trying to figure out who has COVID and who doesn't. And the problem was, at first we thought it was limited to, you know, a fever and a sore throat and a cough with maybe some sputum. And then you find out there's rashes, and then you find out there's diarrhea and loss of smell and loss of taste. And so it very quickly became, well, how do we try to dice through and figure out who can we bring in safely that has allergies or bronchitis, and who really has COVID? And that was very challenging for the staff. One of the things that we early on tried to do was, as we diced through who we thought had COVID and who we didn't have COVID, we did some template management where we tried to separate the sick and the well. And even that was challenging, but we would put the well patients in the morning and the sick patients in the afternoon so that we could clean up the rooms at night. And then by the next morning, you know, we had a period of time where the air could clear from the patients who had been in the clinic in the afternoon. You're doing virtual visits. At one point in the height of this, I was probably at about 60% virtual visits in my practice. But it was not without challenges, because finding a platform that worked well, that was HIPAA secure, that patients could easily use. We at first were using a platform called Amwell that Ascension has used quite a bit. But as people started using it a lot, it started freezing up. It was really difficult for patients who had poor bandwidth at home to get on. So I know I kind of migrated as time went on from that platform to Google Meets to then now using Doximity, which is kind of where I've sort of settled now, is with Doximity, because especially for my older patients, many of them have a smartphone, so they know how to push a text because they know how to text their grandkids. So they can get on pretty easily with Doximity. The other thing was, risk reduction for the staff in the clinic and our other patients. So, looking at things in the clinic, like, do we have candy dishes that were sitting out that people would be sticking their hands into? Did we separate the chairs in the lobby? Putting up some face shields, plexiglass at the windows in the clinic, masking it at one point, coming through the front door, having temperatures taken and patients screened for symptoms to try to stop them if they made the mistake of trying to come anyways, even though they knew maybe they were sick. But I think one of the challenges I still have is, I'll have a patient who's sick and they want to be seen, but they really can't be seen in my clinic. So finding a place to get a COVID positive patient seen who needs to be assessed. And we were able to eventually get a respiratory clinic. I'd say the last two things are caring for nursing home patients, which was really challenging since their families can't get in to see them. Had to make arrangements with the nursing staff to get them to do the virtual visit with us so that we could get the patient on camera and talk to them and see how they were doing. And then, of course, we all love the variation in insurance policies and how they'll pay for virtuals. And so, I found myself at many turns doing way more work on virtual than I could actually capture reimbursement wise. So that was very challenging.
Excellent. Thank you for 3 great answers. And so the second question is going to start off with Dr. Gross, and that's, how has your practice and responsibilities changed as a family physician?
So as Dr. Patton just said, it's really about, the main change has been telemedicine, and that it's been accepted. Before, I think telemedicine was kind of this science fiction-y thing where, yes, we had phones, but it was a kind of a virtual reality thing, and not, even just a year or even 2 years ago, it was not widely accepted. Everyone knew that insurance wouldn't pay for it, and docs weren't real keen to it. Necessity is the mother of invention, or at least in this case, the mother of expanding this tool. But I think that the main change is that cultural change amongst patients of, this is okay. It's okay to not have a physical exam, even though personally I think that especially with musculoskeletal stuff, it's borderline malpractice to not do an exam. But there are a lot of things that can be addressed through telemedicine, and now that's been an acceptable thing. It's not weird anymore to say, hey, I had a telemedicine visit and we discussed this, and this. It's also not weird to have a telemedicine visit with your physician for reassurance. And I will tell you, at least in the past month, a lot of my telemedicine has not been about making a diagnosis or confirming a diagnosis. It's been more about reassurance that, hey, I'm not too sick to go to the grocery store, or hey, my chronic conditions are this, but they're relatively stable, don't you think, doctor? And so I think that change and that cultural change is likely to stick with us even after the pandemic becomes a terrible, terrible, terrible memory.
Excellent. Thank you, Dr. Gross. Dr. Patton?
Yeah, as I alluded to, I have been doing upwards of 60% virtual at some point. So I agree with John that the patients and the staff actually began to accept it. At first, we sort of thought, wow, can we really do this? Can I really assess and diagnose a patient through the computer? And what am I going to miss? What are we going to miss? And it turned out we actually have become pretty good at it. I'd say the biggest thing that's changed in my practice is the worried well. I see a lot of patients both virtually and in person who probably don't really have anything going on, but they just really, they want to get out of their house and go someplace safe and talk to somebody and try to understand what's going on in the world around them. I'm seeing a lot of anxiety, a lot of depression, especially in kids and adolescents who have been home for a while and haven't seen their friends, and their parents, really don't want to let them go out and do a lot of things. And so the kids are very sad about that. A lot of weight gain. People talk about the freshman 15 in college. I have a lot of my patients now joking about the COVID 15 because they're not getting out and exercising as much. I have to say, I've never seen, since I did OB years ago, I've never seen so much telogen effluvium. That was something very interesting that I noticed in my practice, is just a large number of women coming in who are losing their hair, and they were all convinced they had thyroid issues. They were all convinced something was terribly wrong with them. And I began to realize, my gosh, they're all going through telogen effluvium from the stress of COVID-19, just from everything going on around them. Delayed well care, not getting surgeries done. I have a lot of patients who are not getting imaging and procedures that they really need because they're afraid, as John said, to go to the hospital. But then you walk through the hospital and you're like, boy, there's nobody really here. It's probably actually pretty safe in the hospital right now. And then your own staff wellness challenges, keeping them healthy. A big one for me is keeping up with the changing information on COVID. I try to read as much as I can, and every day there's something new coming out. Today the kids get it, tomorrow they don't get it, the next day. So it's just a huge moving target. But one of the best things I heard somebody say this week was, hey, let's not forget, nobody's an expert on COVID-19. So you have to take everything you read and see with a grain of salt. And then, honestly, another big one has been patient expectation versus evidence-based medicine. A week doesn't go by that you don't have people calling still asking about a Z-Pak or hydroxychloroquine. And so, being able to calm their fears and let them know, no, I'm not withholding something from you that you really need. I think those are the big things that I've noticed.
Excellent. Thank you, Dr. Patton. And Dr. Carrick?
So I agree with everything that Mo and John have said. Just, I guess in my world, just try to keep it simple. I've divided up kind of into two major spheres in terms of how my life as a physician has changed. One, the physical. Folks have talked about most of those things. The one that we haven't talked about, it must be the word, it's definitely the word of the month or word of the pandemic for many people is, and John and I always thought the PPE was a pre-participation physical exam, but it's actually personal protective equipment. And going from a person that could barely tie a tie, now I can do protective gear going in and out of patient's room pretty quick. The one issue that we always worry about still is are we always going to have enough? And if we have upswings in diseases and cases of COVID, is there going to be enough PPE out there for us, for our patients, for our staff, and for our nurses? The telemedicine, besides the communication, all that has really improved our access for patients. And John said it very nicely, is that a lot of those are just reassurance visits. They just want to hear that things are going to be okay, or we can get them a test pretty quick and I'll get them right back with the results, and so they can continue to live their lives as they had before. In terms of the cognitive aspect of it, and I didn't know how to put it specifically, but it's kind of taking the pulse of your practice and taking the pulse of your staff and your nurses. And one is if they get too excited, too concerned about stuff, kind of bring them down, saying everything will be okay. We have the gear. We're going to do everything right. We know what to do today, at least, as Mo said, things change, but we have it fairly under control today. But then also remind them COVID is still a big thing, and we have to remain vigilant. We have to be prepared, and we have to make sure we take care of folks. The one part, and it talks about the changing recommendations for COVID and how we maintain the standard of care as we're caring for these patients. What I've learned is with these things, you have to be flexible. What's written in pencil about COVID today can be erased and written in crayon tomorrow. And then someone will paint over that crayon and do something else the next day. So you just have to keep up with stuff, and just as everyone said, no one's an expert in COVID. Things are going to change. We're going to learn more and more. And I remind folks is one good aspect of it is, months ago, the death rate from COVID was much higher. Recently, I think folks have kind of seen the decrease in the mortality rate. One is younger folks are getting it. Two is we're getting better at taking care of people with it. So there's been, that aspect of it, and sometimes you just have to remind people of that. And then finally, and maybe folks can write in and tell me, but I'm still looking for a very consistent, accurate source of information. It's hard. I go to the CDC, I go to Johns Hopkins, I go to JAMA, I go to New England Journal of Medicine, and they're all very wonderful sources. And they run something sometimes, the next day they have to rebuttal it. But I think we just have to accept that, because this is a novel virus that we just have to work through.
Excellent. Thank you. Just three great insights, just because our practices have changed greatly. So we're going to move on to question number 3, and this is going to go to Dr. Padden. What poses the biggest threat to you and your patients in the coming months of the prolonged pandemic?
So I think one of the things that already has been a challenge for us is, when we lose staff for whatever reason. So, if somebody is sick and has to call out, whether it's COVID related or not, it's difficult to get backfill. The depth is sort of disappearing. I work in a system where, we normally have a pool of staff that we can pull from when people are sick or out. But, a lot of those folks have been redirected to work in other areas and doing testing and things like that. So not having the extra staff that you can pull when folks are out, not having that depth is, I think, as we get into the fall, going to be very difficult. I think the staff worry about, am I going to get paid? So if I'm sick, if I'm furloughed for 10 days because I'm COVID positive, what happens to my pay, and how does that affect the family? I know a lot of the staff worry about that. Gaps in care, I talked about this a little bit earlier. If patients put off having imaging or having surgery, well, what are we missing? And what risk are they putting themselves at? We saw in Italy where plenty of patients avoided going out of their house and accessing care, and then they were found sometime later, deceased in their residence. So many of my elder patients are very much isolating themselves, like really haven't left their home since March. Like their telemedicine visit with me might be the only time they've talked to somebody in 4 or 5 months. What about increased mental health issues? Again, if they can't, we already have a hard enough time getting people in, at least in my community. I'm sure it's the same in yours, and to see a psychiatrist, because there's just not an overwhelming number of mental health professionals in the United States. But this has made access, even more difficult for patients, especially those who might be more socioeconomically, not having an internet, not having a computer, that they're not tech savvy enough to be able to do that. What do we do if the schools close? Like, what if we do get to that point where we open up the schools and we have outbreaks and we have to revisit going back to virtual? Who's going to care for all those children? That affects the patients and their livelihood. It also affects the livelihood of our staff. And I already talked about the isolation and death at home. I see primary care potentially being tasked even more in the future. We are a pluripotent stem cell for all in terms of purposes, and we are 911 when people have a shortage. So I could see where we could be tasked to become hospitalists and inpatient folks and helping out. If we were to have another outbreak, are we going to be pulled to be working in other areas? I worry about COVID, flu, and pneumonia all at the same time. Pick your 2, pick your 3. When we get into September, October, November, do we have a lot of folks who maybe get them all at the same time? And I didn't add it to the list, but one of the things that's really on my mind right now is testing. And can we move from a very expensive, high sensitivity PCR test that is prone to a lot of staffing delays in results, equipment breaking, maybe to a lower sensitivity rapid test given multiple days throughout the week to increase the turnaround on testing, get the answer, maybe isolate people a little bit more, which bends the curve down a little bit. So I think if we keep on our strategy of testing right now, we're maybe at risk. I think we have to be a little bit more agile in how we test out from here on and do community tracing.
Excellent. Thank you, Dr. Patton. Dr. Carrick?
Oh, you're muted.
Yeah.
There you
Dr.
go.
Carrick,
I got-
on your,
My apologies.
there you go.
Yeah, making sure we maintain our vigilance in combating the virus. Making sure, I know we have about 40 to 60,000 students coming back to UF this week. And making sure that they remain vigilant, making sure they're wearing their masks, washing their hands, and not congregating large masses. Getting patients back into face-to-face visits so we can take care of their other chronic conditions. Not only patients that have low risk, but the vulnerable patients, and how do we best protect them from getting the disease. And then finally, continued about the information, either the good information or the bad information that we're all receiving. And that just seems to be at times spiraling out of control, but then at other times, you're getting really good information from the CDC, for instance, and it's very helpful when they update their algorithms and provide you kind of state-of-the-art evidence-based algorithms to help you care for these patients.
Excellent. Thank you, Dr. Carrick. Dr. Gross?
So in answering this question, I went very macro as far as the biggest threat to the medical community and the patients at large. I really feel like having a misalignment of incentives from those that hold the cards, whether it be, I use the term large corporate medical or medicine administrators, and that could be anything from HHS and Medicare to large insurers, to large medical groups, to even just politicians indirectly. And so, my answer has a political bend, which may not come to anyone's surprise, because I think that those types of decisions have that downstream and trickle down effect on a lot of the things that have been brought up by Dr. Carrick and Dr. Patton. So I think a great example is the schools opening. We have not had a very strong centralized response to that. It has been very local as far as the decisions to open schools. I guess you could say that the largest level that it's been decided is at a state level in some of the states, but for the most part, it's actually school to school, at least here in Florida, as to how much PPE the teachers are going to have, how much preparation is being made. And I feel like those decisions are not necessarily being made by those that are knowledgeable in medicine, but rather those that are either in a political position or have a financial position. So, other concerns that were brought up about, I think Dr. Patton's point about primary care being increasingly tasked plays into my point, which I think that like large medical groups and hospitals are not necessarily going to have their incentives aligned with the public health needs, and will task primary care physicians when they get into a bind with what Dr. Patton suggested, which is inpatient care and more nursing home care. And clearly we're always at the ready, but I think that will be a big threat, kind of an ominous threat as the pandemic kind of rages on. That if we don't have those incentives aligned, there's going to be a lot of people being asked to do things that aren't in their or their patient's best interest.
Thank you for the great answers. So it's just an interesting time. So I'd like to move to the last question tonight, and this is really the heart of this presentation. We really want to look at how do we find our health here? How do we, find our personal health and encourage just family physicians across the state to be the best they could be? And so the question is, and we're going to start with you, Dr. Carrick, how are you staying healthy, mentally, physically, et cetera, as well as encouraging your family physician peers in Florida and across the country?
So I'm staying as healthy as I can be. I try to maintain at least the work-life balance I've had as long as I've had it. And my schedule really hasn't changed a whole lot. I've tried to maintain it because it kind of gives me a foundation from which to go to. Regular exercise, but I do, the basic things you do for not only physical health, but mental health. I always tell all my sons, I run and I ride bikes, and I really hate running, but I feel so good when I'm done, that it's worth the whatever 20 to 40 minutes worth of pain for the rest of the day, that I just feel so much better when I do it. And I sense that because on the days that you really don't want to do it and you do it, you feel the best. And that goes into the rest of the day. Make sure you get adequate diet, eat regularly, stay away from the junk food, the fried foods, the fast foods. Make sure you eat though on a regular basis. Adequate sleep, and I'm definitely not the poster child for getting enough sleep. I can tell you that. But at least I'm trying to do more. And I don't know about most folks there, but COVID is kind of wearing me out a little bit. So I am sleeping a little bit more at night. And it's just been over the last month or so, but just the number of questions and decisions and issues that you have to address during the day seem to be a little bit more. And so I've taken that into account and just make sure I go to bed at a reasonable time. And then hobbies. And I've avoided, and I'm trying to really get rid of the hobby of watching the news, because that just tends to mess up everything, I think. And we've added more hobbies. We're making some woodcraft out in the garage. We started playing more games at night. I have a son and my wife live here, so we pick card games. We pick Rummikub on some nights. And if I leave early, that's because it's video game night. And we have to go do that as a family. My wife and kids laugh at me because I'm the worst video gamer ever. But at least they can beat me pretty thoroughly. Next, and I learned this, if you're a read good to great, but also Jane Stockstill, actually I'm from Charleston, South Carolina. He actually was the president of one of the small colleges there. But he was a prisoner of war during the Vietnam era. And he maintained or had this philosophy that understanding the need to address the current crisis, which we feel is COVID, but also maintain hope for a better tomorrow. And I always remind our folks that even on the worst days, there will be a better tomorrow. This is a pandemic. There's been multiple pandemics in the past. There have been multiple crises. This is almost like our world war, but it will come to an end, and we'll have better days ahead. And even better than that, we have to plan for those better days ahead. So when there's moments in your day, please send suggestions and ideas of what you imagine the world is like next year, post-COVID. And let's start planning for that, because that gives you hope, and it gives them an idea that, yes, this will end, and we'll move on. As we're doing tonight, and other folks have talked about, use different technologies for more socialization. Though I am getting a little Zoom fatigue. I may have to change to GoToMeeting or some other platform. But it's the best we have for now, and enjoy it while you can. And then finally, on a regular basis, I send an update to our faculty and to all our staff about what things are going on. And I use pointed phrases, I use outlines to try to keep it brief but to the point. And this was just something I wrote one time, and I got several feedback from it and said it kind of hit the spot for them. But just trying to keep the main thing, right? We're here to take care of patients. We're here to teach students, learners, and we're here to provide some leadership and hope for the future for our patients, for everybody. So as long as we're doing that, as long as we're keeping everyone as safe as possible from the COVID, and we're trying to address varying levels of discomfort as we're trying to do all that, that's a busy day. And that fills my calendar up. And that's why I'm getting exhausted at night, I think. But overall, it has been one of those instances where it's the worst of times with the best of times, because you have seen so many people come together to address this pandemic, and really brings out the best in, I think, a lot of people I work with, a lot of my patients, and I really think it's bringing out the best in what a family physician can do.
Excellent. Thank you, Dr. Carrick, for the great practical advice and the hope. And I think it's really well needed right now. So, Dr. Patton?
Yeah, so I really miss seeing a lot of my friends. No surprise anybody that knows me as an extrovert as I am. I'm a very social person and I like to go out and hang out with my friends a lot. And so this was a big change for me to not have that freedom to go socialize and go places with people as much as I like. I remember in the very beginning of the pandemic when everybody was isolating at home, the stay at home order was in place. And of course, we were all going to work because, we had our practices and we needed to see patients. I would come home from work and get out of my car to walk in the house, and my neighbors would all be sitting on their porches and they would say to me, "Oh, I can't wait for this to be over. I'm so sick of watching Netflix." And I'd come home from work and I'd say, "I'm so glad I get to come home and sit on the couch and watch Netflix." So, it was a different perspective. So for me, one of the things that's really helped me is Facebook chats with my friends and with my niece who we just did a baby shower for on Facebook, trying to still do those things that you would have done before, but finding, new and unusual ways to do it. It's not unusual on the weekend for me to have a Facebook chat group with a bunch of my girlfriends with a glass of wine. And they're all doctors, and we all talk about what's happened in our various places where we're residing around the United States and the world, because some of them are still in the military. Playing golf. I hadn't played golf in 15 years. And I said, I can play golf. It's outside, it's safe. So I'm playing golf again now. So I'm playing golf. I was a big Orange Theory person, but I couldn't bring myself to go back into Orange Theory and work out anymore in the closed environment. Not so much because I was afraid of getting sick from them. I was afraid being a doctor, I'd get it from one of my patients and bring it into them. So I bought a Peloton and I've learned to really love riding my Peloton, and I still get to connect with my friends that way. I started gardening again. You're not going to believe it. I have 3 chickens now that I'm raising, and I can't wait till they actually lay some eggs because it's a lot of work. So they better give me some good eggs. Not a lot of great data, but I'll tell you, I've gotten into taking vitamins now. I'm taking vitamin C, quercetin, vitamin D, and zinc, trying to do anything I can to be safe. I wear a mask religiously. If I think somebody might be sick, I definitely put on a face shield. I took up sewing again. I hadn't sewed since high school. Went to Catholic high school and the nuns taught us how to sew because back then that's what you did. Hadn't sewed in years. Took my sewing machine out, and as much as it pained me, I made an Alabama mask for one of the other doctors and then said War Eagle as I gave it to them. But sewing masks with different designs just to cheer the staff and people up, and my family and friends, that's kind of kept me busy and given me something to do. But I think the main thing is I really try to encourage my staff and the other docs that I work with is there is no reason to come in if you're sick. If you're sick, stay home. Like, just don't worry about it. I was talking to one of my staff tonight who is sick, and I said, we will be fine without you. Please stay home. Don't come in. Don't worry about it. Because our first thing is always to come to work sick and keep working and taking care of patients. So that's been something I'm really encouraging people. And then just getting really serious about the cleaning protocols in the clinic and making sure that patients who come in with masks that are too big and flopping off their face, I'm happy to replace it with a proper mask so they can come back into the spaces. But those are just some of the things that we've been doing.
Excellent. Thank you, Dr. Patton. And it's funny, I think most physicians I talk to have their supplement of choice for COVID-19. I've been trying black seed oil, which for 5 months, and it still tastes like turpentine every night. But I think for some reason it just works in my mind. So, but I think all of us have something that we're trying in the supplement world. So, lastly, we're going to go to Dr. Gross. But before that, we're coming to the end of the presentation. So if anybody has any questions that they want to ask this amazing panel, please send so in the chat box. And we're going to finish up here with Dr. Gross on the last question.
Right. So as far as me staying healthy during this pandemic, there's 2 main things I was looking at. Exercise. I preach exercise. Exercise is medicine. Exercise is preventative. I'm preaching to the choir, of course, with this on this webinar. But mostly getting outside and doing the exercise there, that has been cathartic for me because of all of the stressors that are looming, whether it be insurance companies or the patients, or worrying about one scenario or another at the office. Exercise is that catharsis that hits the reset button up here, and I've been super busy, but I was reminded by this cartoon that busy is relative, and when you have that perspective, it's not so bad to get up in the morning and go for a run. So the other thing that I've done is stop watching the news. And if anyone knows me, I am a political animal, and so I watch the news a lot to get my information as far as what's going on in the world. And when I was searching for things that illustrated that point, I knew I needed to stay away from the political bend. And the internet did not disappoint as far as finding a ridiculous headline that would illustrate why we are so stressed out by the news feed that we have coming here. So all I could find was a headline. I don't know anything else about the story, but I am truly intrigued, and we'll take to Twitter later. But as far as encouraging my family physician peers, to echo what my colleagues have said, it really is about reaching out. What I say over and over and over is during this time to my colleagues that have either expressed dismay or pointed out that that this is just so fatiguing to them professionally, is keep the faith. Keep the faith and remind yourself why you are doing the good things that you do for your patients. I felt like this slide pointed out what family physicians value, and I find myself in one way or another saying all four of these things to those that are just sick and tired of being sick and tired due to the COVID-19 pandemic. So clearly you can read this, but being committed to comprehensive care, being concerned for your patient population no matter the age, and delving into what COVID is all about and trying to understand with the best of our ability for all the information and misinformation that's out there, and understanding how this disease affects the mind, body, and the spirit, and then appreciating how all that stuff affects the context of the patients that we see day in, day out. And in one way or another, I bring all four of those concepts to those that we talk to, or that I talk to, when we're lamenting how rough it is to deal with this pandemic.
Excellent. Thank you. And again, great answers. It's been just a wealth of just practical information tonight, and we really appreciate the three of you and just this wisdom that you're sharing with all of us. So I have a question. Just what is something that you've done for your staff that has landed during this 5 months? Like, is there one best practice or best practices that you can give that's really lifted your staff's morale, during this time?
So I'll take that. It'll be a weird answer, but being consistent with sending people home. You can be rather willy-nilly about policy, and I found that staff appreciate when you are consistent about who goes home and who doesn't. Once you start to kind of veer away from that policy, then it calls to question. And why does this person get to go home and I don't, and whatnot. And it was not on purpose. It was actually by accident that we got that response from the staff. That consistency was, I think, appreciated more than anything else.
And I'd like to echo that, because the one is keeping them as up to date as you are on COVID, and giving them the answers that they like to hear or need to hear, giving them direct communication, making decisions that, oh, you look sick, you have a fever, no, go home. And we'll check you tomorrow. There's no wavering. There's no like, well, could you work another day? No, just direct decisions, helping them kind of keep structure during this time of upheaval. The other is a lot, I'll say a lot of face mask time, right? Instead of FaceTime, now face mask time. So I tend to walk around the clinics more. Go visit we have 6 clinics in Gainesville, so I go walk around them. And I wear different masks all the time, but just go around, walk around, and just show them that you're there, that you're willing to be in the front line with them, but also you have their backs.
Yeah, I think just doing little things for my staff has really helped a lot. As I allude to, one of the things that I did early on was I ordered a bunch of fabric in different team, for different college football teams, for different things that I knew that they were interested in, and made personalized cloth masks for each of them. And they showed up on their desk one morning when they came into work, and they were super surprised, and they liked that. They couldn't imagine that their doctor took time to sew them a face mask on the weekend. The other thing is, I scurried into Bath Bomb Works, whatever that store is called, where they have the really nice smelling hand sanitizer, and scavenged up some great hand sanitizer in small bottles that smells real nice. I bought a bunch of bottles of that for the girls and put it on their desks. And, they really kind of appreciated that too. And I just think bringing them in coffee, bringing them in, donuts, and we try, my nurse practitioner and I try to just show them, hey, you guys are working hard, we know it, cutting some people out to go home a little early here and there when we have the chance. We've just tried to do little things to make them feel better.
Excellent, thank you. It's just really good advice that each of us could bring to our practices. The next question is, how are most doctors dealing with the economic impact on our patients and our own lives?
Day to day, week to week. I mean, it's I think the degree of uncertainty with how the macroeconomic effect of the pandemic and the microeconomic effect of the pandemic does not allow for planning. And it's the only planning you can really do is take that conservative approach and hope that people adhere to the preventative measures so that you can stay in business and have as much staff as possible to see the patients that you need to see, and you stay on top of all of the financial changes and the regulatory changes that seem to be fast and furious these days. So I wish I had a more defined answer, but from my perspective, it really is just day to day, week to week, and figure it out.
And then also the 2 things I've seen, that's our thunderstorm here, I think. One is, minimize expenses for patients or minimize expenses for your practice, and try to hold on to that. And I know our organizations, we've tried really hard not to do furloughing, laying off folks, and we've really just tried to, to minimize expenses. No more travel, no more food. Just trying to minimize so we can not lose people. The other, and it's not I told you so, but it's for future reference, is it's that approach to you have to have a certain amount in savings. Every business does, every individual does. Some people say the 3 to 6 months of emergency funds, right? And I think things like, not only has this pandemic shown that things like that are important to continue to do, but also things like controlling diabetes, controlling hypertension, watching your weight, doing the preventive stuff. So when things like this come up, whether it's preventive for physical illness, preventive for financial problems, or other issues, those basic preventive activities are just so important.
Yeah, and I think I've really tried to focus on making sure I ask that question because, having come out of the military and practicing in an organization for 30 years where people didn't have to worry about how sick they could afford to be, I've become keenly aware as I've come into the civilian world that many patients struggle to be able to pay for their blood pressure medications. So I try to be really cognizant of, are you able to pay for your medications? What can I get you free at Publix or on the reduced cost list? What can I get you to resources? Thankfully, I work, for a Catholic nonprofit hospital, and so there's a lot of avenues to help patients to get the care. But I also try to talk to them about, well, what needs to, we get so focused on CG caps and quality metrics and making sure we dot the I and cross the T. But, I'm in that situation now where I'm like, well, what has to be done now and what can wait till next year or next week? And maybe it doesn't have to be done right now. What's urgent and what's not urgent? What can wait? And I think patients appreciate that when you can do that. I feel lucky every day that as a doctor, I don't have to worry about financial stuff. Thankfully, being retired from the military, having a great job now. I've actually been busier, honestly, the last couple months than I even was before. So I'm very thankful for that. But I try to be really cognizant for my staff and my patients because I know that's not true for everyone.
Just one last thing, it's really emphasized to me that I know we all don't like filling in those forms they bring in, right? The disability forms, FMLA forms. But in this time, that can help them get an extra paycheck or two, or help them get the extra finances that they need. So I know I was talking to a group of residents the other day, and they were saying, well, who should fill in these forms? Somebody's got to do it because that means a paycheck to these folks. So we have to help them out.
It's a great reminder, Dr. Carrick. So we're gonna have some fun with the last question of the night. So we're gonna put each of you on the spot. This will be fun. So we're gonna actually get your crystal ball out. When will things return to a greater sense of normalcy? So, and why? So.
Well, I'll take this one first. I'll tell you, I think this is the new normal for a while. When I look at this virus, the novelty of it, the fact that I'm not convinced herd immunity is going to maybe come as quickly as we think. I don't know how fast we're going to get a vaccine. I think this is going to be with us for a while. I see this going on for probably another year. This could be very similar to the flu, where it mutates and getting consistent immunity for a long period of time may not be possible. I'm glad that we've developed some new strategies like virtual, telemedicine. I don't think that's going to go anywhere either. I think even after this gets better, if it goes away, I think we're going to keep doing business differently than we have in the past, because I think patients are learning that it's safe and they can do it and they like it. I honestly think this is going to go on for a while. I think it could be a year.
Dr. Patton, this is Jay Milson, the EVP. We've had a number of requests that your answer be disqualified because that might mean that we can't go to the Ritz in December. So we're going to have to redact that from the recording.
I second that.
Just kidding.
So I'll be next. So I won't give a time frame because I really want to go to the Ritz. But I think things have changed, but then they're also going to retract some. And I think we're going to go back to some, 50% new, 50% back to normal. It seems like we're getting better at treating the disease. At times it seems like we're getting better at controlling it, and at times it seems like we have no control. And I think that's going to fluctuate over the next several months. I'm hopeful a vaccine will come out sooner. And it just makes me think about previous viruses or illnesses that have had in the past. The 1918, it went away, but it had 3 waves and it was pretty persistent for several years. Polio seemed to go away pretty quick. And I don't know how effective the vaccine is going to be. Is it going to be a polio-like vaccine, or is it going to be an influenza-like vaccine? And I think that's probably the one thing that's going to be the game changer, is how soon the vaccine can come out and how effective it is. If it's an effective vaccine, then it'll be matters of months. If it's a flu-like or less effective vaccine, then yes, it could be a year or two.
So I thought about having fun with this question, but I'm actually going to answer it seriously. Just being in sports med, we've been inundated with all of the precautions and how do we play and be safe with this illness. And my personal opinion is that I think that normalcy will return after we make some mistakes with football and other more contact sports. I think that there probably will be some outbreaks related to football. There already have been. And so the season will go forward. We'll have a secondary wave from those asymptomatic younger people that inadvertently do lead to more spread. So I'll just say May 1st of next year. I'll take a date, and that's when the effects of the football season will be off, and it'll be just in time for the virus to mutate, and we have another season not unlike the flu season again. Sorry to end on a downer.
Hey, this is Mo. If I can make one more comment, I think one really important thing is because I think, like I said, I think it'll go on for a while, but I don't think it has to be bad for a while. That's an important caveat. I think if we, as a country and as family physicians, if we really try to push for people to be more thoughtful about how we do things, this could be not so bad. When you look at the young folks, yeah, they may get it, but they won't be necessarily as affected. It's really the elderly population, I think, that is probably going to suffer the most through this in terms of how their life has changed. But I think if we can get really smart about frequent, low cost, self-done testing at home by folks to avoid them going out, the R0 can be lowered on this virus, I think, to a very, very low level. And we can go back to our lives understanding the risks, and then people can, kind of decide how much risk do they really, really want to take. I think it's going to change lives more for some than for others. And so I don't want to be a downer about it. I just think it's going to go on for a while. But I think, man, we have some wonderful opportunities to try to control this virus and how it spreads through, community spacing and testing and tracing, and just being really smart about how we do things.
Thank you. And any closing points? We're getting ready to wrap up. We're getting close to the 9 o'clock hour, and so just want to offer each of our three great speakers an opportunity to make a closing point or pass. Just let us know.
So yeah, we got to figure out something that could, I guess, hope or cheer up after those two. No, but they're right. It could go on for a while and all that stuff. But every day is a new day. Things can change overnight. The pandemic seemed to come upon us fairly quickly. It could leave tomorrow. It could leave in several months or years. But there's always the opportunity, I think, as Mo just said, to make it a better world tomorrow. So as long as we keep that up and keep looking forward, I think folks will do well.
Yeah, I think that one of the inadvertent benefits of this is that for every meme that you see on the internet that talks about how people are not being very considerate to each other by not wearing masks and so on, I personally see people being more considerate and acknowledging that they are wearing a mask to protect other people. And if that bleeds into society and takes us a notch higher as a result, all the better.
Yeah, always look for random acts of kindness to do.
I guess my only closing comment would be there's never been a better time to be a family physician. And I'm not saying that to be funny. I mean, I really mean it. I think if people have learned one thing through this, whether it's the patient or folks who work in the medical world, and that includes subspecialists, I can't tell you how many of them have really said, boy, you guys are the ones that are there getting it done, taking care of the patients. And I think people really appreciate that. And I think our community has really stepped up.
Thank you. And on behalf of the COVID-19 task force, the FAFP, just our hope with this webinar was to encourage each of us to be the best we could be, to help our patients to be their best selves, and the three of you have really, exemplified that and really gave some practical advice on how to do that, and just to keep encouraging, even though it is a tough time. We just have to find hope in the tough time and spread that hope. And so I really just thank the three of you tonight for just doing an amazing job with that. And so just want to thank Dr. Carrick, Gross, and Patton for an excellent presentation, as this helps FAFP members reflect on their own actions and reaction to the COVID marathon. Also, I'd like to thank all of you for joining us tonight, and to not forget to continue to visit the FAFP website, fafp.org, for late-breaking information concerning the COVID-19 crisis, and to listen to any past webinars on demand. That includes remaining on the lookout for our next webinar that will be held sometime in mid to late September. I'll close by noting that the FAFP COVID-19 Task Force will continue to meet and determine ways to assist FAFP members practice in what has become the new normal of family medicine. In the meantime, do not hesitate to reach out to FAFP staff if you have any questions or need assistance, as they will help navigate your specific inquiry. We appreciate all you're doing on behalf of your patients. Keep up the great work. Be well, stay safe, and good night. Thank you.